I think everybody can hear me. My wife usually tells me I'm loud and I speak too much. So I'm going to just talk to you a little bit. Okay. All right. So what I want to do is give a brief talk on how to pick a surrogate, what are the criteria that we use in order to find the best surrogate, talk about single versus double embryo transfer, what are the risks with double embryo transfer, the risks with twins, should we do chromosome testing before we put the embryos back in, and then ultimately what I'd like to do is really open the floor to your questions, because I think in the process of answering questions, we'll talk about a lot of practical things that are going to really help you navigate this journey to parenthood. So I'm Daneshmand. I'm the director of the Fertility Center in Las Vegas. I did all my training at UCLA, my training in obstetrics and gynecology and fertility. And one of the things about our practice is we do a great deal of research. I was talking to you guys, yes, I was talking to you about you know, what distinguishes one practice from another, and I think one of the things that it does is research. We do a lot of research in the field of IVF, and our research has been presented around the world, in the United States. Next weekend I have to do a day trip in China presenting our research over there, because they're very much interested in the latest technologies in in vitro fertilization. So I think our research has really allowed us to achieve great pregnancy rates. We welcome you to go ahead and take a look at our pregnancy rates over the last 5 years from SART data, looking at pregnancy rates not only with double embryo transfer, but really looking at single embryo transfer pregnancy rates as well. So let's talk first about the steps, the first step, which is really choosing a surrogate. Dr. Shapiro is going to talk to you a little bit about choosing an egg donor. I'm going to talk to you about, you know, how do you choose a surrogate. So what we want to do is, we have certain criteria for surrogates. We want them to be in good general health, good mental health. We want to make sure that they've had previous pregnancies without any complications. We want them to not to be doing this process just for compensation. In other words, we don't want them to be in bad financial shape. We want surrogates that are intelligent, in decent financial shape, who are going to get compensated for this. And a lot of them actually are women who've had easy pregnancies or have been happy being pregnant. They haven't had any complications with the pregnancy. And I think they really, their heart goes out to parents, intended parents who need to go through surrogacy in order to be able to have their children. So I think we've really had the pleasure and honor to be able to work with some great surrogates over the years. Darcy's going to talk to you a little bit more about that. So once Darcy presents you with some profiles of candidates, these are some of the things that I want you to look at in terms of how many pregnancies have they had? Have they had any complications during pregnancy? How old are they? We want surrogates to be between 21 and 39 years of age. Above the age of 39, there's a higher risk of diabetes, high blood pressure, and complications during pregnancy. We look at not only the previous deliveries, previous pregnancies, we also look at birth weights, for example. Especially some of you would want to transfer 2 embryos to have the genetics of both partners in the pregnancy. But if we want to do that, if we want to transfer 2, we have to make sure that we choose a surrogate that is able to carry 2 pregnancies close to term, because with twins, the biggest risk is at preterm delivery. If you have twins that are born at 28 weeks, 29 weeks, 30 weeks, then your children are going to be in an intensive care unit for weeks and weeks and weeks. And not only is that a financial risk, but also obviously the most important thing is the health risk, because children can have problems in lifetime when they're born early. So we have to make sure we're very vigilant and very careful in picking the very best surrogate, especially if we want to transfer 2 embryos back to the uterus. We generally recommend a single embryo transfer, but if you twist our hand, we will transfer 2, but we definitely want to consider a surrogate who's going to have the best chance of having a healthy delivery. What happens is, after you speak to Darcy about choosing your surrogate, she's going to send me some profiles, and what I do is I go over all the medical records of the surrogate. So I look at her previous pregnancies and make sure that there were no complications, there were no issues like high blood pressure or abnormal blood sugar, diabetes, those kinds of things. Once we do that and we figure that, and I will help you, again, I'm going to be with you throughout this whole journey, so you don't have to ever worry about that you're alone in terms of picking your surrogate. I'm going to be reviewing the surrogate right alongside of you to make sure that we pick the best surrogate. Once we have a candidate that we think is a good surrogate, then that surrogate comes to our office and we do diagnostic testing on the surrogate. And the testing includes psychological screening. So we do a very extensive psychological test with a PhD psychologist. We test her uterus to make sure that there's no abnormalities in the uterus, such as fibroids, polyps, any growths that can prevent the embryo from attaching. We do a urine test on them, a urine toxicology screen to look for drugs and medications. We do an extensive blood screen on them, which includes things like blood sugar, insulin levels, thyroid hormone levels. We look to see, a lot of surrogates will tell you, well, I'm taking my prenatal vitamins, or we're not happy with that. What we do is we actually measure the vitamin levels. So we measure vitamin D levels, folic acid levels, vitamin B12 levels. Why? Because deficiencies in these vitamins are associated with complications during pregnancy. So if you have, let's say, a surrogate that's taking her prenatal vitamins which have folic acid, but she's not absorbing it and her folic acid levels are low, that increases the risk of an abnormality called a neural tube defect, which is essentially a spinal defect again. So we want to make sure that we are as meticulous as possible in not only choosing the surrogate, but then doing the diagnostic screening. Once we've done the diagnostic screening, that's when the process, the in vitro fertilization process starts. And of course, Dr. Shapiro will talk to you a little bit more about picking the egg donor, but by this time, you've also picked your egg donor. You're more than welcome to use our egg donor database. We have a directory at our clinic, and we have a great team, Tish, Ashley, Sarah, Amity, and they'll be able to help you look at our donor database and pick the donor that you wish. And again, we have the same criteria for the donor. Donors tend to be between 21 and 29 years of age. Again, we want to make sure they're healthy. And also, it's important for them to look at their family history to make sure they don't have any family history of any genetic illnesses. So now we do the testing on the donor as well, the same test, plus we do an extensive genetic screen on them. For example, we look for things like if they're carriers for Tay-Sachs or thalassemia or cystic fibrosis. Once the donor and the surrogate have completed their diagnostic testing, then you start the process that Kim is going to talk to you about, which is the contract between you and the surrogate. And then once the contracts are in place, then we actually start the IVF process. So your donors are going to get medications for 11 days, so we give them injections for 11 days. And in those 11 days, we're stimulating their ovaries to mature and develop multiple eggs. At the same time your donor is taking medications, your surrogate is also taking medications to prepare her uterus. So at the same time we're monitoring the surrogate, we're monitoring the donor as well. Once we take the eggs out, and I want to show you kind of a photo of that real quick. So now, once we've taken the eggs out, that's a typical egg right there. And what we do is we call you the same day and let you know how many eggs we retrieve from your donor. And many of you would want to have 50-50 fertilization. 50% fertilization with one partner, 50 with the other. So then what we do is we do the fertilization, we take the sperm, we inject it inside the egg in a procedure called ICSI. And we pick out and select the best quality sperm, inject it inside the egg to fertilize the egg. Now we have a fertilized egg right here. And then from this stage, there's an attrition process. What happens is not all the embryos are going to make it to a stage called the blastocyst. Usually only about 40% of those embryos that are fertilized, actually 30 to 40% make it to blastocyst. So by the time, typically on a donor, we get about 15 to 20 eggs, we usually end up with about 4 to 6 blastocysts right here. So when we end up with 4 to 6 blastocysts, typically what we do is we transfer 1 or 2, and then we freeze the rest of the embryos. We expect if we transfer 1 embryo to have over a 70% chance of live birth. When we transfer when we transfer 2 embryos, we expect more than 85% live birth rate. But we have the risk of twins, and typically the risk of twins is over 50%. Now, when we get to this stage of the embryo's development, some of you may want to do something called chromosome screening, or PGS, pre-implantation genetic screening. What is that? Let me go back on these slides. Is it the right click to go back? Good. So we have the option of doing something called PGS or PGD, which is when the embryo gets to the blastocyst stage, we take a few of the cells of the trophectoderm, because the blastocyst has an area of cells called the inner cell mass, which gives rise to the baby, and then the other cells give rise to the placenta and the gestational sac. So what we do is we create a little slit, a hole here, and we take a few cells out. And then at our clinic, we have our own genetics institute, so those cells actually go off to the Genetics Institute, and within about 12 hours we get the results. And what we look at is we look at all 23 chromosomes. Why do we do that? Well, most of the time it's because to make sure that there's no chromosomal abnormalities with the embryo, such as Down syndrome, those kinds of chromosomal abnormalities. And then other times there are some parents who wish to have either a son or a daughter, and so you can also look at the gender when you do the PGS. Having said that, you don't need to do this exam when you use donor eggs, because PGS and chromosome screening was really developed for women over the age of 35 who are using their own eggs. Or for example, if you find an egg donor that's going to be over 35, no, we don't have egg donors over the age of 30. So typically, the risk of chromosomal problems is much higher with eggs that are older than 35. And so when you use donors that are typically 24, 25, 26 years of age, the risk of chromosomal problems is very low, and this is something that we don't recommend unless you wish to have it. Now, what are some of the circumstances where we do this test? Let's say you find a surrogate, and she says that if there's any problems with the baby, like a Down syndrome, she's not willing to stop the pregnancy. And you say, well, I want to have the option of doing that. So what we can do is we can do this chromosome test before to make sure there's no chromosomal abnormalities. Again, the risk is less than 1 in 1,000 when you're using egg donors with healthy eggs of finding an abnormality, a chromosomal abnormality. And when there is a chromosomal abnormality, well over 90% of pregnancies that have chromosomal abnormalities will miscarry before 10 weeks of gestation. So sort of nature takes its course within the first trimester or first 10 weeks of pregnancy. So when we transfer the embryos, or embryo, 5 days later we get a blood test on your surrogate, and that blood test will tell us if she's pregnant. And then we follow the pregnancy in the first 10 weeks to make sure that the fetus or fetuses are developing well. We monitor the hormone levels for the surrogate. And then at 10 weeks of pregnancy, then we transfer your surrogate to her OBGYN. So we're in contact with you all the way through 10 weeks, but actually, practically speaking, in the majority of our intended parents, we're in contact with them all the way until delivery and even afterwards. We were just in Spain about a month and a half ago, and we had a get-together with all the intended fathers and their children, and we all went out to dinner. And so you become part of our family when you go through this journey with us and when you have your children. So we want to have a relationship with you and keep in touch with you for a long, long time. Also, for some reason, if the embryo transfer with the fresh embryo transfer doesn't work, well, what we can do is we can get the surrogate ready the next month with the frozen embryo transfers. So in our clinic, Guy may have told you, we never charge for frozen embryo transfers, and of course with our unlimited program, it's essentially a guarantee to live birth. Even if we have to retrieve more eggs or use the other embryos that are frozen, or even have to change surrogates, there's no additional clinic fee that we charge. One of the things we also have to encourage single embryo transfer is we have something called the IVF family package, so that if you want to have more than one child, we can transfer one embryo, and within 6 years after the birth of that child, you can come back to us, and as long as we have frozen embryos, you can do another cycle, another journey with us. Again, there's no clinic fee with our family package. So a little bit something, again, we talked about this earlier. Selecting a center, you want to make sure you look at the birth rates. You want to make sure that you look at the number of transferred embryos in different clinics, because some clinics can increase the pregnancy rates by transferring 3, 4 embryos, which we think is dangerous. Look at implantation rate, and also look at frozen embryo success rates, because if the fresh embryo transfer is not successful, then what we do is we rely on the frozen embryo transfers to get you to a pregnancy. Now, let me just stop here and see if there's any questions before I introduce Dr. Shapiro, so he can talk to you a little bit about the donor side of the journey. Yes?
2 questions. The first question is, we're talking about the chromosome test. Is there any danger in making this exam?
Excellent question. About 10 to 20% of embryos, after you do the chromosome test, can stop developing. There's no danger in the sense that there's no harm to the baby. If the baby develops, there's no harm. But sometimes when you do the chromosome test, some embryos are fragile, so that embryo can stop developing. Now, that embryo can stop developing in the lab, or sometimes you transfer the embryo and the surrogate could have a miscarriage. So there is a small risk. We think that the risk is somewhere between 10 to 20%.
See, but then you have the frozen embryo that you can...
Exactly. You have the frozen embryos, exactly right. So there is a risk, and we always tell patients, there is a possibility that with the chromosome test, that the rate of pregnancy will decrease a little bit.
The second question is, you talked about the difference or the difference in danger between a single embryo and a twin. So maybe you can elaborate about this.
Sure. So if you look at the danger, for example, let's look at things like diabetes and high blood pressure. Twins have a 15% higher risk of diabetes, 15% higher risk of high blood pressure, and a significantly higher risk for a surrogate, exactly right. And remember, all these complications such as diabetes and high blood pressure have an effect on the pregnancy. Because if the surrogate's blood pressure is not controlled, then she has to have a preterm delivery. If her diabetes is out of control, diabetes can affect the health of the pregnancy. So twins are higher risk, and we have some surrogates, for example, who've had twins before, and those are actually good candidates for carrying twins again. But typically we want to make sure that the surrogate is in the best physical shape possible. And we also look at something that's very interesting that some clinics may not look at. When you have a surrogate that's only had singleton births, one of the things that I look at is I look at the birth weights of the babies. So if you have a surrogate, for example, who's had 6-pound babies each time, that may not be a good candidate for a double embryo transfer for a twin pregnancy. But if you have a surrogate who's had heavier babies, 8 pounds, 8.5 pounds, that uterus is able to probably carry the pregnancies a little bit longer time. Because typically what happens is when the uterus gets to a certain point and is stretched to a certain point with twins, it's going to start contracting and wants to deliver the baby. So we look at birth weight as well. So there's a lot of things that go into it. And in our first consultation, when we sit down and discuss what you like to have done, whether you want to transfer a single or a double embryo transfer, these are some of the things that we discuss. And if it's something that you want to do double embryo transfer with, then we definitely want to find the right surrogate for you. Yes?
How many double twins births from two separate people you had already experienced, and what is the rates if the number is big?
So, so about 30% of our patients have twins, which we think is too high.
Twins from two different...
Yes. In other words, if you look at all our intended fathers that we do surrogacy on, about 30% of them have twins, and that's when we transfer two.
30% of 20 or from 3,000?
Oh, you think the total number that we do?
Yeah.
You're talking about 30 out of this is per year, about 100. So have twins, but the twins are the ones we actually transfer two embryos back in. This year we had a stretch of the year where we had 24 consecutive pregnancies with single embryo transfer, which we're particularly proud of because each one of them was just a single embryo transfer, and so we had 24 pregnancies in a row. So I think we want you to have a pregnancy, and it would be great if twins had the same risk as singletons, but we also want you to have healthy babies, and when you come to the United States, we want your babies to be healthy to come back home with. So that's why we always discuss with you the risk of twins. Now again, there are many fathers who've had twins without any issues, and you've got someone right here who's had that. I had one of my couple's intended fathers in France had a surrogate who had a pregnancy before the pregnancy was close to 9 pounds. She had twins for our intended fathers, and she actually went all the way up until almost 40 weeks, and she went to the hospital, and she was just relaxing in the bath of the hospital, and she delivered one of the babies in the bath, and then the other baby they had to catch really quickly. So sometimes you have those situations where babies don't, even twins, they deliver. So if you talk to my intended father and fathers in Paris, this particular intended fathers, they'll say twins are great. We had no problems. The baby stayed in the hospital for 2 days, and they were gone. That's it. But there is a risk. The risk is small, but it's much higher than a singleton birth. And then sort of the scenario that's even more complicated is when you transfer 2 embryos and one of them splits. So that's when you get a triplet pregnancy. That only happens about 1 out of 100 times. But that triplet pregnancy, then we consider potentially sometimes reduction because we reduce from 3 to 2 sometimes to improve the probability and the health of the other 2. Yes?
Well, I would ask a question.
Sure.
Your choice.
So I want to understand better the risk, okay?
Right.
You say there is a risk to the surrogate.
Yes.
What is the risk to the babies or to the unborn babies?
Well, the risk is that remember that with twins, you're looking at about if you take 100 twins, about 15 to 20 of them are going to be born before 35 weeks of pregnancy. And depending on how many weeks the pregnancy is at, whether it's 28 weeks or 30 weeks or 32 weeks, the babies have to stay in the hospital. So what are some of the risks with twins? For example, twins can sometimes have bleeding in the head. Sometimes twins don't feed very well after they're born. Sometimes they have growth issues where they're not growing as well. They have to stay in the intensive care unit for a longer period of time. With the modern technology that we have now, twins are doing preterm, really preemies. We call them micro-preemies. Micro-preemies are really small babies. They're doing better and better, but still there could be problems. For example, sometimes twins can have problems with learning behavior. For example, the first time when they speak, it's a little bit delayed. Speech can be delayed, learning. So these are all possibilities, but those things happen when you have really, really premature babies. If you're talking about 27 weeks, 28 weeks, because the longer the baby stays in the uterus, the more mature the organs become, and two of the organs that we really want to mature is the lungs and the brain. Because if the brain is somewhat immature, you can have bleeding in the brain, and if the lungs are immature, then you have breathing problems, so that twins have to be on respirators, and you have to help them with their breathing up until they're able to do it on their own.
I might not using the right medical terms, but when you putting the eggs back into the womb, what is the name, what is the medical?
Oh, transfer?
Transfer. When
Right.
you transfer the eggs back, is there less success rate when you do it with twins than with single?
Oh, that's a very good question. Slightly. So you're looking at somewhere around a 70–75% success rate if you put one embryo back in, and about an 85% when you put two embryos back in. So there's about
a higher success with the twins?
With two. When you transfer two embryos, there is a higher success rate.
For the two to be, for
you transfer two. Yeah, if you transfer two, there's a higher success rate. But we never want you to make the choice of transferring two for the higher success rate, because we have a program where if we do a single embryo transfer, if it doesn't work, and usually we have frozen embryo transfers, we just get the surrogate ready within 4 or 5 weeks, and we do another single embryo transfer.
So after 4 weeks, she can do it. You can do
she can do it again. Exactly right. Because what will happen is, if it doesn't work, the surrogate will have her menses, and then we can get her ready again in about 3 weeks and do another transfer. So so we don't want you to do two embryos to be transferred to increase the success rate. We will get you success if that's a concern. The only time we want you to transfer two is if you really want to have two, the genetics of both of you, and you want to do it now versus having one child now and then maybe a couple of years later your second.
Continue. About the procedure.
Right.
Your study procedure, basically the procedure is done in Nevada, which means that you control the procedure. After the transfer, the surrogate still stays in Nevada?
No, depends on where the surrogate is from. So typically, we have some surrogates from Nevada, some surrogates from California, some surrogates from other states.
So they go back to their home place?
Exactly right. So we do the transfer, they stay for a few days in Nevada because they have to rest after transfer. And then what we do is we have sister clinics and colleagues all across the United States. So they may go back to California, and basically what we do is the surrogates only need to be seen about every couple of weeks to make sure that the pregnancy is growing well. They have an ultrasound, they have blood work. So we do weekly blood tests on them. So they go to a lab and they just send us the report. And then we also send them to our colleagues in wherever they are in California, whether they're in Oregon, it could be in any of the states where the surrogacy is allowed. And then we get all the reports. So we're still following.
There's a clinic next to the surrogate. I mean, there is always a clinic that you're in touch with.
Always, absolutely.
And when you are back to the picture?
When we...
Back to the picture, I mean, then that's it. I mean, that means the babies are being born in their own clinic or the whole hospital.
Right, so then what happens?
She doesn't come back to the clinic.
No, exactly right. Because after 10 weeks of pregnancy, then she goes to her regular OB/GYN. Now, if she's having twins, we send her to a high-risk pregnancy specialist.
Hi, Bruce.
Hello.
So,
Hi, Dr. Shapiro. Hi, Bruce.
Hello.
So Bruce, if you want to discuss a little bit of the sort of the donor criteria, and we talked about transfer and embryonic development, but if you want to talk about a little bit of the donor criteria.
Okay, great, great. Excuse me if I cough a little bit. Well, the main things that you want to know about when you look at a donor are, one, do they satisfy the appearance and background that you want? So what we have is we have a database, and you're able to go on that database and see what their general appearance is. The other things that are very important are, of course, their genetic background. You want to make sure that they don't have any genes that they're carrying that might be a problem. And that if you also carry one of those genes, there would be a 1 in 4 chance of having a baby that might have a particular problem. For instance, if you carried a Tay-Sachs gene and they carried a gene for Tay-Sachs, then the baby would have a 1 in 4 chance of getting that. We also want to make sure that these don't. We also want to make sure that the donors are very healthy. We want to make sure that they're psychologically healthy, and we want to make sure that they're physically very healthy. So we put through a large amount of screening. So for the genetics, they get a very comprehensive genetic screen, and we use Counsel Diagnostics, and this puts them through a sequence of evaluations to make sure that they aren't carriers for any of the common 104 different types of gene mutations. We also check their chromosomes to make sure that they have a normal number of chromosomes, although many of these women have had children before, and that is most likely not a problem, but we want to make absolutely certain. We interview them directly. So Dr. Daneshmand and myself will actually interview each one of these donors to make sure that when we kind of look over them, we know that these are the kind of donors that we actually would like. And if we look at them and go, you know, I don't think I'd want that as my donor, we wouldn't certainly choose it for any of our clients or patients. So in order to make this whole process work, we need to have a donor, of course, that meets all of the prerequisites. They have the appearance that you want. They have no problems with their genetic background. They're healthy, both psychologically and physically. We have them go to a PhD psychologist who does a personality inventory on them to make sure that there isn't any psychological problem lurking that could possibly be passed on to any offspring. So once we've seen all that, then the other thing that we need to know about is, well, what's going to make this a successful cycle now that we've chosen a donor that looks like she meets all of our criteria? And that's going to be the number of eggs. The number of eggs the donor has is directly proportional to the likelihood that the whole process is going to work. And the reason for that is as follows. If we have a woman who makes 20 follicles or 20 egg-containing cysts in the ovary that we can see on ultrasound when we're monitoring them, we're going to expect to get about 14 eggs, about 70% of those. Of the 14 eggs, we expect about 10 of those to fertilize. Of those 10 that fertilize, we expect about 7 to divide normally and to continue the process of development. And we expect 5 to make it to the very end point of development, just prior to the point where we're going to put them back into the uterus. And of those 5 that make it to the very end, only 3 to 4 will be of sufficient quality to be able to result in a baby. So you can see the number of eggs in humans is very, very important. Now, there are some donors that make a smaller number of eggs, and they do quite well. But the majority of donors, the more eggs you have, the greater the likelihood that you're going to make the process successful. But on top of that, we want to have extra embryos left over so that we can freeze them. And the reason for that is because if in the small percentage of cases that it doesn't work on the very first transfer, we want to have some frozen embryos that we can thaw and put back in another cycle. And if you do get pregnant immediately, we want to have some embryos that are going to be available for you in the year or two down the road when you may want a second pregnancy. So number is very, very important. Now, some of the things that you won't ever see or know, because we'll screen these patients out ahead of time, is if they have some kind of personality problem, or they have another type of problem that we think is going to make them non-compliant or not follow directions. Because we want women that are able to follow our instructions rather precisely. But we weed all those out before you ever see them. But these are pretty much all the things that go into choosing a donor. Now, most of these donors are absolutely marvelous women, marvelous. They really want to help people make families. They really feel dedicated to it. They're very, very nice, and they're just a real joy to work with. And that's overwhelmingly the majority of these women. Well, I hope that answered some of your questions, on donor eggs. Does anybody have any questions for me? Yeah, in the United States, these are mostly anonymous donors. There are special situations where you can meet your donor, but that would be a direct donor. So that would be a slightly different situation, and Kim Surratt can talk to you about different legal implications that would involve. But most of these are you can see their pictures online, but you don't really know them, and they don't know you, and you really never meet them.